Hello, everyone. Welcome back to another day of our review session for the NCLEX. And for those who are already in the classroom, welcome back. And for the newbies to the channel, thank you for joining with us today. I hope that you can hang out with us until the end of our lecture today. And we are inviting everyone to enroll into our NCLEX course via www.stancoast.nclexcoaching.com. We have our resources that are available for you in your subscription for the 6-month period. We have upgraded our on-demand videos. That includes the 200 hours of recorded lectures plus the 20 hours of animated video series. And we also have the 200 NGN test questions and the 3000 NCLEX questions as well. Now, kindly check in the description box below, and you will be able to also know more about us. And so if you haven't liked or subscribed to this channel, please do so. And if you could share this video to your friends who are also reviewing the NCLEX, we would really appreciate that. So today we'll be continuing in our review, and we'll be focusing on the endocrine system. And today we'll tackle more about the type 1 diabetes mellitus. So let's get started with the first question. It states, a 32-year-old male with type 1 diabetes shares how he manages his blood sugar while exercising. Which of his habits suggest he needs more guidance from the nurse? Is it A, he ensures to carry hard candies whenever he exercises? B, he takes a brisk walk when his blood sugar is 200 milligrams per DL. C, he eats a peanut butter sandwich before going on a bike ride. Or letter D, he increases his daily exercise routine when he detects ketones in his urine. So this is on a patient that has type 1 diabetes mellitus. And you're going to identify in the options those habits that would require your education. So which of the following here you think should be corrected? And we are talking about a patient that is type 1 diabetic. Well, if you had answered letter A, this is incorrect, because this is actually a good practice and it can help quickly raise the blood sugar levels if there is hypoglycemia occurring during an exercise. Take note that this is a question asking for a negative habit by the patient that we should be correcting. So if you had answered letter A, this is something that will not require any additional teaching. This is a habit that actually signifies that there is correct understanding about avoiding any complications. Alrighty, what about letter B this time? He takes a brisk walk when his blood sugar is 200 milligrams per deciliter. We know that engaging in a moderate exercise when the blood sugar is about 200 is generally safe, and it is recommended for this type 1 diabetic patient. It can help lower their blood sugar levels. So this is also incorrect. If you had answered letter C, he eats a peanut butter sandwich before going on a bike ride. What does that pertain to? Well, having a peanut butter sandwich in this scenario is a good strategy to maintain energy levels, and this will also prevent the hypoglycemia. So we don't have any other choice left but letter D, which states he increases his daily exercise routine when he detects ketones in the urine. We know, guys, that with type 1 diabetes mellitus, exercising can actually lead to diabetic ketoacidosis. Take note that there is an absolute absence of the insulin in their body. They're not able to manage that. And so even so, if they're going to engage themselves in a strenuous exercise, the blood sugar will not be delivered into the cells because they don't have that insulin as a key to deliver the glucose, right? So what's going to happen instead is that they're going to break down those fats, and this will be converted into the of course, free fatty acids, and this will be reflected in their high ketones in their urine. So basically, this is going to lead to a DKA. So they should not engage in any exercises like this one, especially if their blood sugar is already skyrocketing. It will only lead to DKA. It should be avoided when there are ketones detected. It can worsen their hyperglycemia. So we are selecting letter D. Let's move on to item number 2. A patient with type 1 diabetes wants to start swimming laps for an hour each day at 1 p.m. What should the nurse teach the patient about managing this new routine? Is it A, check blood sugar before, during, and after swimming? B, postpone lunch until after the swim session? Or C, increase the morning dose of NPH insulin? And D, time the morning insulin dose to peak during swimming? We are talking about this patient that engages in swimming session for about an hour each day at 1 p.m. So what will you do here as the nurse? Teaching this patient in managing their new routine. Would that be A, B, C, or D? If you had answered letter D this time, time the morning insulin dose to peak during swimming. Well, take note of the statement here. Time the morning insulin dose to peak during swimming. This is the most dangerous time for this patient to experience the hypoglycemia. This is actually can put them at a higher low blood sugar. And so we definitely need to carefully manage the dosing schedule, ensuring that they do not coincide with the physical activities that can lower their blood sugar levels. Do not let this happen, guys, especially during a physical activity. This should not happen. What about letter C? Increase the morning dose of NPH insulin. We know that the NPH is an intermediate insulin, right? Yeah. So if you had answered letter C, increasing the morning dose of NPH could also cause the hypoglycemia during or after the exercise. Morning dose of NPH. Remember that this is an intermediate insulin. So what does that mean? This is going to start working. The onset of action here will start in about 1 to 2 hours. And it has a peak of about 6 to 14 hours. So take note about the time here. Increase the morning dose of NPH insulin. So that's basically around breakfast time. And take note the time of the swimming session, 1 p.m. So that's approximately about 6 hours after they take that NPH insulin. So again, this can also cause the hypoglycemia during or even after the exercises. We know that the peak of the NPH will range from about 6 to 14 hours. We are eliminating this option as well. What about if we answer letter B, postpone lunch until after the swim session? Well, if you are going to let them delay their lunch, take note about the NPH action or the peak, which is about 6 to 14 hours after the injection. This can also lead to the hypoglycemia, especially if they are skipping lunchtime. The more that they'll experience a severe form of hypoglycemia. We don't have any other option but letter A. Check blood sugar before, during, and after swimming. This would safeguard this patient with a type 1 diabetes from experiencing the hypoglycemic effect of the medication. All right, so make sure that you emphasize this. They need to check it before, during, and after swimming. So your key here, guys, is to really refamiliarize the type of insulin the patient is taking. Let's head out to tackle number 3. What is in number 3? The nurse realizes the patient with a newly diagnosed type 1 diabetes needs more education when the patient says, A, I should have a snack at bedtime because I take NPH insulin at night. B, I can eat whatever I want as long as I take enough insulin to cover it. Or C, I can drink alcohol occasionally if it fits into my meal plan. Or letter D, I need to eat something at meal times to avoid low blood sugar, even if I'm not hungry. So your patient is a newly diagnosed type 1 diabetic. And the question is asking for you to identify that statement that would need more education. So which statement is that? So if you answered letter A, I should have a snack at bedtime because I take NPH insulin at night. Take note about the intermediate type of insulin, NPH. Remember about the onset of action and the duration of action, which is 6 to 14 hours. Remember, this is taken at bedtime. Do you think this is something that would require education? No. Actually, this is a good statement from the patient because having a snack at bedtime is going to prevent overnight hypoglycemia when they take this NPH insulin. So we are going to not select that one. What about letter B? I can eat whatever I want as long as I take enough insulin to cover it. This is the correct answer that we are looking for. Take note of the statement here. I can eat whatever I want. Nope. We know that we can give them some room of flexibility, right? Especially in choosing the food items. But they must plan their diet carefully, not just having to eat anything what they want. They need to have a focus on balancing their nutrition rather than just covering calories with insulin. It would not be a good idea to just take anything what they want and then give themselves with higher doses of insulin, because this is what it said, as long as I take enough insulin to cover it. So basically, this is dependent on the amount of food that they are taking as they desire, and that is a risky kind of a treatment plan for them. So this is inefficient and also a very unsafe practice by this patient. Okay, if you had answered letter C, I cannot drink alcohol occasionally if it fits into my meal plan. We know that occasional alcohol intake is acceptable if it does not exceed the caloric and carbohydrate limits, because it's also high in carbohydrates. So occasionally, if it fits into my meal plan. So that is having that conscious state of mind about the alcohol intake, that it can also lead to increase carbohydrate intake. So we are not going to select that one. Same. What about letter D? I need to eat something at meal times to avoid low blood sugar, even if I am not hungry. Well, it seems like this patient doesn't really understand the calculation of their carbohydrate intake or even the calories, because they're actually adding more stuff into their meal time. So this is not really having a consistent amount of the calories that is dedicated to that particular meal. So we are also not I need to eat something at mealtimes to avoid low blood sugar. Hang on a second. Letter D. I need to eat something at mealtimes to avoid low blood sugar, even if I'm not hungry. This is actually a consistent intake at mealtimes. It doesn't mean really, I'm sorry, it didn't mean that he's going to eat extra, but actually he has to be consistent in taking in that food during the mealtime to prevent the hypoglycemia. So this is also a correct habit by that patient. So we are not selecting that. So we are going to keep our letter B as the correct answer for this situation. I can eat whatever I want as long as I take enough insulin to cover it. Let's have number 4. What patient action shows proper understanding of how to administer aspart insulin? Is it A, the patient avoids injecting insulin into the upper abdomen, or B, the patient cleans their skin with soap and water before injection, or letter C, the patient stores the insulin in the freezer between doses, or letter D, the patient pushes the plunger while removing the needle from the skin? Which patient action shows proper understanding of how to administer Novolog insulin? Would that be letter A, or B, C, or D? If you answered letter A, the patient avoids injecting insulin into the upper abdomen, that is an incorrect option because the upper abdomen is the preferred site for the insulin injection. The word avoid or avoids. The upper abdomen is the preferred site for the insulin administration because it has that consistent absorption rate. If you had answered letter D, the patient pushes the plunger while removing the needle from the skin, this practice actually is a good one. The patient should leave the needle in place for a few seconds after the injection to ensure that they get the full dose, right? Rather than withdrawing it immediately. So this will allow the administration of full dose. So you're going to keep the needle in for a few seconds after you push the plunger. Again, this will ensure that the full dose is delivered. So we are going to what? Is this a correct answer? No. Pushes the plunger while removing. That is the phrase right there that makes the statement incorrect. They should leave the needle in place for a few seconds, not remove it right away once they push the plunger. Letter C, the patient stores the insulin in the freezer. Are they supposed to put that in the freezer? It should not be frozen because it can actually degrade the medication. Not putting that in the freezer. We can keep it in the refrigerator, but not in the freezer section. We don't have any other choice. But letter B, the patient cleans their skin with soap and water before injection. Yes, in the home setting, they can do that. This is an appropriate method for ensuring that their skin is clean before they administer their insulin. This is one way of actually promoting hygiene before they self-administer the drug. Okay. They could administer their insulin right after, maybe using that alcohol swab, or they can opt this way of skin prep, right? They can use that soap and water. Let's have a number 5, which action by a patient using an insulin pump shows they understand its use well. Is it A, the patient administers an insulin bolus after meals? Or is it B, the patient changes the insertion site once a week? Or letter C, The patient removes the pump at night and reattaches it in the morning. Or letter D, the patient increases their caloric intake when using the pump. We're talking about the insulin pump this time. So which of the following practices shows that the patient understands the correct what do you call this? Correct administration of insulin through that device? Would that be A? Would that be B, C, or D? Take note, guys, that the insulin pump is supposed to be on their body pretty much the whole time, okay? Except for those time when they're going to need to change the appliance. I'm talking about the needle, or if they're going to have to get that insulin pump refilled. Of course, those are the exceptions, right? If you had answered letter D, the patient increases their caloric intake when using the pump. Well, they need to increase their intake of calories. We know that the pump actually will offer dietary flexibility, right? But it does not really justify a higher calorie intake or calorie intake without the consideration of their blood glucose, right? So this is a wrong practice. Increases their caloric intake when using the pump. They need to maintain a much more of a balanced diet, and this is something that is required to make sure that they are managing their diabetes in a much safer way. Okay. What about letter C? The patient removes the pump at night and reattaches it in the morning. Would that be a correct practice? The pump should not be removed at night. This pump is actually supposed to provide a continuous basal rate of insulin, and it should not be removed. Okay? There is such thing as the basal rate of insulin that is actually pre-programmed in that insulin pump. And so if they're not applying that pump at nighttime, this will cause hyperglycemic spikes overnight. So this is not a good practice. If you had answered letter B, the patient changes the insertion site once a week. Once a week. Oh boy. Once a week. This is not a safe practice. The insertion sites should be changed every 2 to 3 days. Should be changed every 2 to 3 days, not once a week. And the reason for changing the insertion site is to prevent the infection. It will also ensure that there is consistent absorption. Okay? Prevents infection. And also it prevents the lipodystrophy, because if this is going to be changed less frequently, then it can cause that subcutaneous layer to become atrophied. Okay? It will not be able to allow absorption if this is going to be used in a longer period. And so that's another reason we're going to have to change the site to prevent lipodystrophy. All right, so these are the two reasons why the site should be changed at least every 2 to 3 days. If you had answered letter A, the patient administers an insulin bolus after the meals, this is what we are looking for. The patient should know already about adjusting the pump in order for them to deliver a bolus of insulin after the meals. This is an appropriate action. It will help manage their glucose much more effectively. Okay, so The bolus is basically going to be dependent on how much insulin, how much glucose or calories they have taken for that particular mealtime. Okay, so that is the bolus dose. We don't have any other choice but letter A. Let's have number 6. What behavior suggests a patient using a blood glucose monitor needs more teaching? Is it A, they wash the puncture site with warm water and soap? B, they choose the center of the finger pad to the puncture for the puncture site? Or C, they let their arm hang down for a minute before pricking? Or D, they state a result of 120 milligrams per deciliter is good blood glucose control. Patient using that blood glucose monitor, and this is to identify that action that would require more education. Would that be A, they wash the puncture site with soap, with warm water and soap? Or is it B, C, or D? What would be the best technique? Or actually, this is to identify that action by the patient that is needing more teaching, or something that you should correct. If you answered letter A, they wash the puncture site with warm water and soap. Warm water. Remember about the effect of warm water. Of course, this is basically cleaning the site first before poking, right? So this is an infection control measure. With the use of a warm water, it can actually cause vasodilation, right? It will enhance the collection of the finger stick blood glucose, right? It can cause vasodilation, so it doesn't require teaching. We are not selecting that one. If you answered letter C, they let their arm hang down for a minute before pricking. By gravity, it will allow the blood to at least collect into the periphery, and this can also encourage the blood flow to the finger. So it will be much easier to obtain a blood sample with this technique. So we are not going to select that. If they stated a result of 120 milligrams is good blood glucose control, take note, guys, our patient is diabetic, right? And it didn't really say that this is a pre-meal kind of checking. It did not. All right, 120. We know it's high, right? We know it is high. This is actually a good target glucose range, especially for the diabetics, right? It isn't a value that you should what do you call this? Reinforce teaching, because even though if it is high, according to the values, we know that it should be like less than 100, right? However, with this diabetic patient, we didn't have any information whether it's a pre-meal. It didn't say postprandial. This is actually a random blood sugar reading. Random blood sugar. Check. Right? It can be as high as 120. Actually, when we are talking about a random blood sugar, it could range from about 7 to 160 or even 140. This actually typically indicates good control in people with diabetes. This is a random blood glucose, not a pre-meal, right? So it doesn't really state that, hey, you're not controlling your blood sugar properly. No, it doesn't. We are talking about a random blood sugar level, not a pre-meal sugar. So we are not supposed to select this one. If you selected letter B, they choose the center of the finger pad for the puncture site. Yeah, this is not the best or a recommended site of puncturing the finger. Where you should, the recommended actually is the recommended site of puncture is the side of the finger or the lateral section of the finger, because they have fewer nerve endings and they are less painful. AGI TV 126 is diabetic. We are talking about random blood sugar. We are not talking about fasting blood sugar this time. Okay, so there's a difference between random versus fasting. Okay, take note about the difference between random blood sugar testing. It can be done anytime. It could be either before the meal or after the meal. It didn't state about fasting or like before breakfast. We didn't mention that in our scenario. This is random. So typically when a blood sugar falls somewhere between the 75 to about 160 randomly, this is in the acceptable range. However, if we're going to talk about fasting blood sugar, the acceptable range will be around 75 to about 100 or 110. That is our safe range. So please know the differences between the term random and fasting. So the technique here is basically not the best one, okay? You should be teaching your patient to poke their finger in the lateral section of their finger pad, not the middle part, because this is much more supplied with so many nerves. This is so much more painful, okay? And this is the technique that you should emphasize when they are new to checking their blood sugars at home, okay? Number 7, a hospitalized diabetic patient received 38 units of NPH insulin at 7 a.m. At 1 p.m., the patient who has been off the ward for a chest x-ray for 2 hours has missed lunch. What is the best nursing action to prevent hypoglycemia? Is it A, save the patient's lunch tray for when they return, or B, ask the x-ray staff to start a 5% dextrose IV, or letter C, send a glass of milk or juice to the x-ray department, or letter D, request that the patient return to the unit to eat if testing is delayed? So your patient is out in their unit, okay? So the patient had actually received 38 units of NPH insulin at 7 a.m. And then at 1 p.m., which is basically how many hours is that? 8, 9, 10, 11, 12, 1. So that's 6 hours after the dose. And they have been off the unit for 2 hours. And they already missed lunch. What would be your best nursing action to prevent the hypoglycemia? Imagine this is already 6 or close to 7 hours after their dose of the NPH. This is an intermediate insulin, guys. Take note about the peak of action, which is 6 to 14 hours. NPH. Always think about the peak time, because this is the time when the blood sugar really spikes. It will cause more hypoglycemic effect around this time. So 6 to 14 hours after the administration. What would be the best action here? Are you going to do letter A, save the patient's lunch tray for when they return? Well, this is not really addressing the possibility of having a hypoglycemic patient. Waiting for them to return for a meal tray can result in hypoglycemia, especially if the delay is going to be prolonged. So eliminating that one. If you're gonna select letter B, ask the X-ray staff to start a 5% dextrose. This is basically an invasive action for the situation. And X-ray staff, really? We don't know who this X-ray staff is. This within their scope of practice? Most often what they have in the X-ray or the radiology department, they have the X-ray tech, right? I'm not quite so sure in selecting this answer. You definitely need to make sure that you are going through the series of action here. You don't know anything what's going on in the radiology department. So basically just asking them to administer that medication, D5 IV, it's not just prudent taking that away. What about letter C? Send a glass of milk or juice to the X-ray department. We know that it can prevent the hypoglycemia, but if this is done, it can also lead to rapid blood glucose spikes. And this is not going to be so much helpful for this patient. It can lead to glucose spikes. Comparing letter C and letter D, what do you think would be better here? Request that the patient return to the unit to eat if testing is delayed. This would be the better option for this patient. Have them return to the unit to prevent that hypoglycemic episode, to make sure that they are going to have a much more consistent carbohydrate or glucose level. This is the better approach to maintain that consistent blood sugar level. Okay? Because if you're going to give them an extra milk or juice to the X-ray department, by the time that they're going to return to the unit, yeah, remember the cumulative effects of the extra milk or juice plus the subsequent meal when they return, this can unnecessarily cause their blood sugar to spike. So we are going to select letter D. Okay? Have them return. We are looking for the better nursing, or actually the best nursing action to prevent spikes in their glucose and also to prevent hypoglycemia. Let's have number 8. A 26-year-old female with type 1 diabetes catches a cold and has a blood glucose level of 210 milligrams per DL despite taking her usual insulin. What should the nurse advise? Is it A, use only Lispro insulin until she's feeling better? Or B, limit calories until her blood sugar is below 120 milligrams per DL? Or letter C, check blood glucose every 4 hours and call if it continues to rise? Or letter D, cut back on carbohydrates until her A1C is under 7%. We're still in diabetes type 1, guys. Hello, Chica. The patient now has a cold. And now their blood glucose level is 210 despite taking her usual insulin. What you should do here as a nurse, what would be your best advice to this patient? Take note that in type 1 diabetes, infection, any kind of infection, undue stress can cause extra. It can lead to hyperglycemia in type 1 diabetic, okay? Infection, undue stress, these are things that you should watch for in the type 1 diabetic. All right, if you had answered letter A, use only Lispro insulin until she's feeling better. What is Lispro basically? If you're gonna, if you want to know more about the Lispro, what is the Lispro? This is a what? A rapid acting insulin. Rapid acting. It has an onset of about 15 to 30 minutes after the injection. And what about the peak? This will start to cause hypoglycemia within 30 minutes to about 2.5 hours. So this is the time that you should watch for the hypoglycemia. And the duration, it will last for about 3 to 6 hours. So take note about the Lispro, a rapid acting insulin. If you answered letter A, use only Lispro insulin until she's feeling better. Okay. We need to actually have a better control for this patient, especially that they are having some kind of a cold, a possibility that they're having an infection. This is not really going to manage their hyperglycemia around this time. This is causing, they are at a higher risk to developing the DKA. Not really an effective management. If you answered letter D, cut back on carbohydrates until her A1C is under 7. We know that the A1C is one of those criteria in the diagnosis of the diabetes, right? But the glycosylated hemoglobin is only going to reflect the long-term glucose control. It is not used to measure their current blood sugar level. So it's not going to be helpful in this scenario. This is intended for long-term management. This is to detect if the patient really is following the prescription. But for this patient having this cold at the current time, this will not be really helpful. If you answered letter B, limit calories until her blood sugar is below 120 milligrams per DL. Now, this is not really going to promote a much more balanced intake of their calories. They should not reduce their caloric intake during an illness, because the body this time will actually require more energy to fight off infection. Limiting calories would not be ideal. They should increase their calorie intake when they are ill, because their body would need that to repair those tissues to fight off infection. If you had answered letter C, check blood glucose every 4 hours and call if it continues to rise. We know that this is already hyperglycemia, right? So if you're going to instruct the nurse to do letter C this time, this will help them manage to monitor their blood sugar much more frequently. And if it is not controlled, if their blood sugar will still keep spiking, then it is time for them to call their medical provider to get their dose adjusted. Again, when they are going to be ill, they need to adjust their dose of insulin. Usually it will be a higher dose during an illness. And the reason for that, we don't want this patient to go into a diabetic ketoacidosis. All right, this is something that the patient should be doing. If they are experiencing some type of infection, there will be hyperglycemia. So during stress, infection, they need to get their dose upped by the medical provider to regulate their blood sugar. So we don't have any other choice but letter C. Let's have number 9. A 50-year-old patient has a 6 a.m. blood glucose level of 230 milligrams per DL, and the healthcare provider suspects the Somogy effect. What should the nurse instruct the patient to do? Is it A, avoid eating snacks before bed? B, increase the dose of rapid-acting insulin? Letter C, measure blood glucose levels during the night? Or D, take a longer or a larger dose of long-acting insulin at night. So the healthcare provider is suspecting this patient experiencing Somogy effect. Take note that you have a patient here that has a high glucose of 230 milligrams per DL at 6 a.m. So what you should instruct to the patient this time to prevent this from happening. Take note about the Somogy effect. This is the elevation of the blood sugar, especially early in the morning, around 3 or 4 a.m. What do you think about this? If you had answered the letter C, hang on a sec. If you had answered the letter A, avoid eating snacks before bed. Take note that they are actually having that high blood sugar in the morning. If they're going to avoid eating snacks before bed, this can lead to a hypoglycemic episode in the early morning, usually around 2 a.m. This is going to cause their blood sugar if they are not going to take a little bit of snack before bedtime. So when this happens, there will be a rebound hyperglycemia to counteract the low blood sugar that is occurring. So this is not a good advice. What about letter B? Increase the dose of rapid acting insulin. If we are going to advise them to increase their dose, this is not really a scope of the RN to allow them to just increase without the medical provider's order. And this can also lead to hypoglycemia. And we know that with the Somogy effect, this can lead to a rebound hyperglycemia in the early morning because of the low blood sugar that is occurring at nighttime. Okay, so this is going to cause more of the hypoglycemia. If you answered letter D, take a larger dose of longer acting insulin at night. The longer acting insulin at nighttime basically would not really treat this Somogy effect, as we know that the peak, there is no peak action for the long acting insulin. It has a duration of about 24 hours. It doesn't really treat that Somogy effect. So if you are answering letter C, measure blood glucose levels during the night. This is something that the patient should be doing in order to capture or detect if they are going to run low in their blood sugar, especially in the evening time, or let's say around 9 or 10 p.m., or could be the 12 midnight. This is to detect if there is a hypoglycemic episode, and then they can work around it. They can probably take a little bit of snack to prevent the rebound hyperglycemia later. Okay, so our correct answer is letter C. Now let's talk about the differences between a Somogy effect and the dawn phenomenon. So I hope that you still recall these two variations in the hyperglycemia, especially during the morning. So I would just want you to refamiliarize with the concepts about these two. So what is that dawn phenomenon? Well, basically this is what we have as the hyperglycemia that can happen early in the morning because of the body's natural increase in so many hormones. There are so many hormones that will be involved here. However, if we have the Somogy effect, what is this? This is actually a rebound hyperglycemia after the patient experiences a period of low blood sugar at nighttime. So please take note about the Somogy effect. This is what we refer to as the rebound hyperglycemia. Whereas the dawn phenomenon is basically just consistent increase of the blood sugar early in the morning. However, the Somogy effect will occur when it is preceded by a low blood sugar. Maybe it's caused by not taking enough meals during the evening time, or they may be taking way too much insulin at night, causing the hypoglycemia. Now, what is the exact mechanism in the dawn phenomenon? Well, there is that increased production of those hormones, especially early in the morning. And this could be influenced by the growth hormone, the cortisol, could be the epinephrine, or the glucagon. So these are going to lead into a much more consistent, gradual increase of the blood sugar because of these substances. Now, however, with a Somogy effect, this is caused by excess insulin, or it could be lack intake of food before bedtime. So this can lead to the hypoglycemia before the hyperglycemia sets in. Now, what would be the glucose pattern in the dawn phenomenon? Again, the elevation is going to be gradual, consistent rise in the blood sugar overnight. However, with the Somogy effect, this is going to start initially by having that low blood sugar. There is that initial drop during the night, and then this will be followed by a rebound rise. There is going to be hyperglycemia around 3 a.m. or 4 a.m. Now, what are the symptoms with the dawn phenomenon? Most of the time, they are asymptomatic, but some patients will complain about symptoms of hyperglycemia. Now, for the Somogy effect, because of the periodic, if there is that hypoglycemia that can happen before the hyperglycemia, they will experience the night sweats. They will have nightmares, headaches because of the low blood sugar. They will wake up being shaky. All right. Now, how are we going to manage the dawn phenomenon? We are going to adjust the time and dose of the evening insulin. We also need to make sure that they're using an insulin pump in order to deliver a much more precise dosing of that insulin. And another management for that is we are going to encourage them to consume, for them to consume a very light snack, a protein-rich snack before the bedtime. Okay, take note about the intake. It's protein-rich, small snack. It's not going to be a high carbohydrate, but rather a protein-rich snack. This is going to prevent that, what do you call this? A spike in their glucose level. That will prevent that. What about the Somogy effect? We are going to adjust the dose of the evening insulin as prescribed by the medical provider. And then we also are going to encourage them to consume a snack before bedtime to prevent that low blood sugar. Possibly that's going to happen between 1 or 2 a.m. And this is really going to prevent that rebound hyperglycemia. So that's it for a quick review between the two. Let's have number 10, but before we're going to proceed, we are inviting you to join our NCLEX course at our website. Please check on the description box below for that link. Number 10, a patient who received an intramuscular glucagon injection for hypoglycemia is now conscious. What should the nurse do next? Is it A, check for signs of high blood sugar? Or B, offer the patient a snack with peanut butter and crackers? Or C, have the patient drink some orange juice or skim milk? Or letter D, start a 24-hour IV infusion of 5% dextrose. So your patient who received IM glucagon is now conscious. What should you do this time? Will you do A? Will you do B? Will you give them letter C? Or is it letter D? Take note, guys, glucagon is your reversal agent to treat the hypoglycemia. reversal agent for hypoglycemia. So that's a good sign, right? That they are waking up. Right. So what you should do next, you got to have to select that answer that will not cause more spikes in their blood sugar. The patient already has been reversed. They already received the glucose. So I want you to select that option that can prevent any undue spike in their blood sugar. Something that can only stabilize their blood sugar. Just enough, but don't trigger a spike of glucose. If you answered letter A, check for signs of high blood sugar. Well, the option A, check for signs of high blood sugar, this is actually going to be the incorrect answer. This is one of the incorrect answers because after the administration of glucagon, let me just write this first. After glucagon administration, your patient actually will experience a rebound hypoglycemia. Yes. Why? This will be sensed by the body. Hey, our blood sugar is up again. We need to control this. So this will lead to a spike in the insulin as well. So the more the insulin will be triggered to be released into the system, so there is going to be a rebound hypoglycemia. Signs of high blood sugar? Not really. We are treating the patient for the hypoglycemia. Take note, when they are given the glucagon, there will be an elevation. It will not be elevation like 200 milligrams per DL, but just enough to get their blood sugar within the normal range. But with this effect, the glucagon can actually trigger that rebound hypoglycemia, triggering the release of more insulin. So this is something that you should watch for after the administration of glucagon. If you answered letter B, offer the patient a snack with peanut butter and crackers. What does that mean? Actually, when you are going to offer this, this is a complex carbohydrate and protein. Complex carbohydrate, and also it is a protein, right? Yeah, peanut butter. This is actually going to help stabilize their blood glucose after they receive the glucagon administration. This action can actually prevent the rebound hypoglycemia. Prevents rebound hyperglycemia. Guys, you already treated your patient with the glucagon. You really don't want to give them so much more glucose because it can trigger insulin spikes. The higher the blood sugar becomes, the body will be triggered to release more insulin, especially in this patient. We don't know if this is type 2 diabetic, right? We don't know. But in general setting, if you are going to give them more than enough, this can trigger the release of that insulin, which will lead to a rebound hypoglycemia. But action in letter B actually will help stabilize their blood sugar. So if you had answered letter C, have the patient drink some orange juice or skimmed milk. This is going to trigger that, what do you call this? Hyperglycemia. And this will further trigger that insulin spike as well. This is not going to really provide a sustained stabilization. Take note about the glucose here. This is orange juice. This is a simple sugar that can easily be broken down, right? This is not able to sustain this patient with a hypoglycemia. You got to give them the complex carbohydrate and also protein. Okay? So, when you are treating the patient with glucagon, you should give them the complex type of carbohydrates plus protein, not simple sugars. All right? So we are going to eliminate that one. Letter D, start a 24-hour IV infusion of D5. This is not really a realistic nursing action. It is not necessary for this patient that can eat or drink. This is only given if the patient is not able to take in orally the nutrition. This is an invasive action that is only reserved for those patients that are unconscious. Okay, so we are not selecting letter D. We are going to keep letter B as our best answer. Guys, you have already treated your patient with glucagon. Keep that blood sugar stable by giving them complex carbohydrate plus protein. I can't emphasize that enough. All right, let's move forward with number 11. When assessing a patient with diabetes, which question can help the nurse identify autonomic neuropathy? Would that be A, do you often feel bloated after meals? Or B, have you noticed any changes in your skin? C, do you need more insulin when you're stressed? Or letter D, have you had any painful sores or ulcers on your feet? We are talking about autonomic neuropathy, which is a chronic complication of diabetes. So what would be that question that can elicit this response from the patient? We are talking about autonomic neuropathy. Not peripheral neuropathy. Take note of the word here, autonomic. If you had answered letter D, have you had any painful sores or ulcers on your feet? This is an incorrect option. Simply because this is not a type of autonomic neuropathy. This is an example of peripheral neuropathy. So this is an incorrect option. The patient in diet any pressure, they could also suffer tingling sensation, intermittent tingling sensation, and also the absence of sensation. So they are very prone to developing those injuries. They probably would not notice that they already had a cut in their skin or the soles of their feet. This is an example of peripheral neuropathy. This is not what we are looking for. We are looking for autonomic neuropathy. If you had answered letter C, do you need more insulin when you're stressed? This is a question that is much more appropriate about asking them regarding generalized or general diabetes management, but this is not a question that is going to be specific in asking about the autonomic neuropathy. So this is a broad question, but it will not really specifically get a response from the patient about the autonomic neuropathy. So we are eliminating that one. We are only asking about the increase. Are they increasing their dosage if they are stressed? So this is not going to give a specific response about autonomic neuropathy. If you answered letter B, have you noticed any changes in your skin? Skin, integumentary. This is not specific to the autonomic neuropathy. So the changes in the skin are actually just a variety of diabetic complications, but then again, it will not elicit that response from the patient about the autonomic. We are looking for that autonomic neuropathy. Okay. If you are talking about skin, this is part of your peripheral neuropathy. So we don't have any other option but letter A. Do you often feel bloated after meals? So let's talk about the autonomic neuropathy. So what is this basically? This is a condition wherein it can develop over time. This is going to develop for such a long time that will affect the stomach's emptying rate. Have you encountered the word gastroparesis? Are you familiar with the term gastroparesis? This is that state in the stomach wherein there is a delay in their emptying of those food items. They will tend to keep their food inside their stomach for a longer time, which is beyond the normal period, right? Of keeping that food. We know that glucose usually will stay about 1 hour and a half, protein about 2 to 3 hours, fat can stay about 3 hours. But with autonomic neuropathy, there is that gastroparesis. The emptying rate of the stomach is slowed down. So if you're going to ask about bloating, yeah, that is that specific question that will elicit that response. If the patient will say, yes, I feel bloated after meals, that simply means that the patient's stomach is no longer emptying at the normal rate. There is delay in the gastric emptying. Okay? Gastric emptying. That is delayed. So actually that is one of those signs of autonomic neuropathy. We'll talk a bit more of that in our part 2 session tomorrow about type 2 diabetes. So the correct answer here is letter A. Know the difference between autonomic and peripheral neuropathy. Those are two different manifestations. Let's have number 12. A 28-year-old patient with diabetic ketoacidosis has a serum glucose level of 732 milligrams per DL and a potassium of 3.1 milliequivalents per liter. What is the nurse's first priority of action? Your patient has DKA with a level of 7.32 and potassium of 3.1. What is your first priority action? We're back a little bit on the fluids and electrolytes. What would be the most prudent initial action for this scenario? Your patient has a blood sugar of 732 with a K level of 3.1, and they are in the DKA. Okay. If you answered letter D, initiate an insulin infusion at 0.1 units per kilo per hour. This is not really addressing the complication of the DKA. Remember that your patient has a potassium level of 3.1. And they are in DKA. Remember the complication of this. The patient will be having dehydration because of the osmotic diuresis. What else? You have a hypokalemia right here. What would be the priority. Will you initiate this? If you're going to start this insulin infusion before addressing the main problem, this can further cause a drop in their potassium level. As we know that the insulin will serve as a key into the cell. Supposedly that's the cell right there. We have the bloodstream right here, and our patient has a K level that is low. You have a patient that has a blood sugar level of 732. All right, so if you're just going to initiate the insulin infusion right now, remember about the sodium potassium pump, adenosine triphosphatase membrane, or the pump. The insulin that will be given this time can lead more to a drop in the potassium, as it will allow the entry of the potassium into the cells. This can lead to a severe drop in the patient's potassium level. Take note, guys, the scenario is specifically giving us an idea that there is already hypokalemia. If you're going to give some more of that without treating the main problem, you're going to cause that severe hypokalemia this time. You can control the blood sugar, however, you are also depleting the potassium in the bloodstream. You are leading the transfer or the shift of the potassium ions into the cell. So the bloodstream will now have severe level of the potassium. We're not going to do that. If you had answered letter A, begin cardiac monitoring for the patient, this is what we are looking for. The 3.1 potassium is already low. We need to prevent those life-threatening cardiac dysrhythmias. So assessment first is important. We need to do that cardiac monitoring in order to prevent those complications from happening, such as the cardiac dysrhythmias. Okay. And when the patient has a DKA, it can also lead to the irritability of our heart cells. They are too excited, and that's why they will have that cardiac dysrhythmia, because of the excitability of the heart cells, the myocytes. So we need to make sure we are tracking into the changes in their the heart rhythm, I should say. If you had answered letter B, administer IV potassium supplements. We know that this is also important, right? But take note, the situation is actually calling us to ensure that we are detecting those cardiac dysrhythmias. We are going to focus more about the patient's circulation, right? We know that supplementation is okay. But take note, guys, our patient is also dehydrated around this time. With a DKA, you're not just going to administer the potassium without stabilizing their circulating fluid volume. Okay, take note about this. DKA, there is dehydration, right? Remember what I said yesterday about the replacement of potassium? Make sure you're going to address first. And once you have corrected the dehydration, you're going to start replacing the patient with potassium IV. Because if you're not going to deal with the dehydration first, this can cause the retention of the potassium ions inside the body. This can lead to cardiac dysrhythmias as well. So take note, check correct first the dehydration before replacing. But beforehand, before we are going to intervene, we do need to check the patient's cardiac function, and which is part of our assessment. Okay, so you do first the assessment, and then after you've done your cardiac monitoring, if you have already seen those abnormal rhythms, then you have, if you have done this, connecting them into the cardiac monitor, and while doing that, you can now address their dehydration. Then we can also replenish their potassium levels as needed or as prescribed. Okay. We will be addressing the hyperglycemia as well. But again, we need to prioritize assessment this time because of the cardiac rhythm, cardiac dysrhythmias that can occur in our patient. You need to address the dehydration before replenishing them with a potassium IV. All right. If you would ask about letter C, inquire about the patient's insulin regimen at home. This is something that can be done when your patient is probably much more stable, but not during the immediate phase. You need to prioritize your action this time by at least doing your diligent assessment, then addressing the fluid volume deficit, and then replacing that with potassium. And then we're going to deal with a hyperglycemia right after. Hyperglycemia. Number 13. In the ED, a patient with DKA is admitted. What should the nurse do first? Is it A, administer 1 liter of normal saline per hour? Or B, give a 50 milliequivalent IV push of sodium bicarb? Or C, administer 10 units of regular insulin IV push? Or letter D, start an insulin infusion at 0.1 units per kilo per hour? Your patient is in a DKA mode. What you should do first? You already have a clue from the earlier item. What would be that nursing action that you should do first? Yeah, of course. Because of the dehydration as a result to the DKA. Osmotic diuresis. You're going to have to restore the circulating fluid volume first. This is key because your patient needs resuscitation. Yeah, this is life-threatening. You need to maintain the circulation. You don't really have to address this one because we don't have any issues with the airway, but now we have to treat the circulation issue. Circulation priority. Your patient is hypovolemic because of the osmotic diuresis. You need to stop the fluid loss. Your patient is going to go into a hypovolemic shock if we are not going to deal with that first. Okay? This is the correct answer. Now, let me ask you, why do you think that the patient will experience the osmotic diuresis? Why? Why is this happening? Do you know the reason why the osmotic diuresis is going on for this patient? Remember, guys, about that renal threshold of glucose? The renal threshold of the glucose is around 160. In some books, it states 180 milligrams per DL. Renal threshold of glucose. You remember? That is 160. In some books, it really states 180. So I'll just use that range. Milligrams per DL. So if your patient has hyperglycemia way beyond these ranges, what's going to happen is that the excess glucose will spill out from the renal system. It will escape from the renal system. The kidneys will no longer be able to hold the excess sugar. So the patient will be having what? Glucosuria. Glucosuria, wherein their glucose concentration in the urine is so high. And that is because the kidneys are only able to hold this much of glucose. So in such a case, when your patient has the HHNS, which is the type 2 diabetes type of complication, or let's say the DKA, when they have a blood sugar greater than this range, then what's going to happen is that they're going to spill those excess sugars from the circulation. It will be spilled. It will leak out from their kidneys. That is why they're going to end up with the glucosuria. Well, it doesn't end there. When the glucose escapes into the urine, the water will also follow. So meaning your patient will end up diuresing. They're going to void way too much fluids because it will follow the high sugar content. And so the patient will be prone to developing the hypovolemia. All right. So back to our scenario here on letter B. Give a 50 milliequivalents IV push of sodium bicarbonate. We know that bicarbonate or sodium bicarbonate is one of the treatments, right, in the DKA, but it is reserved in cases that is severe. Okay, so this is reserved for severe cases. What does it do, though? The sodium bicarbonate will alkalinize the bloodstream, possibly because of the pH that is way too acidic, or maybe there's a drop in the sodium bicarbonate level. It could be less than 22 milliequivalents per liter. And again, this is an important nursing action, but this is only reserved for severe cases, not really the main treatment for this scenario, right? If you had answered letter C, administer 10 units of regular insulin IV push. This is something that we can do after we had replenished the patient with the needed fluids, okay? We can address the hyperglycemia once we have corrected their fluid volume deficit. That is the priority, the circulation issue. If you had answered letter D, start an insulin infusion at 0.1 units per kilo per hour. This is also an important action. However, it is going to be initiated after we had dealt with the patient's hypovolemia. Treat the problem first, which is the hypovolemia. Okay? So our correct answer is letter A. Ooh, 1024. We have 2 more items to go. Alrighty, question number 14. A patient recently taken off an insulin drip for diabetic ketoacidosis feels lightheaded and sweaty. What should the nurse do first? A, slowly administer 50% dextrose IV push, or B, give the patient a subcutaneous injection of 1 milligram glucagon, or C, check the patient's blood glucose with a finger stick, or D, have the patient drink 4 ounces of orange juice. So your patient has been treated with an insulin drip, but it's already taken off, recently taken off. Now they are complaining about being lightheaded and sweaty. Yeah, getting sweaty is a bad sign, right? It's a sign of hypoglycemia. Same thing with lightheadedness. So what you should do here as a priority action, will you do A, or will you give them letter B, or are you going to give them letter C or D? Take note, guys, your patient is awake. But before you're going to do anything else, what are you going to do? Your patient is awake. They're not comatose. They're not lethargic. They just feel lightheaded. What would you do in this scenario? If you had answered letter A, slowly administer D50 IV, this is only reserved for those patients with a severe hypoglycemia. So this is indicated for patients who have severe hypoglycemia and who are unconscious. Your patient is not unconscious, eliminating letter A. If you answered letter B, give the patient a subcutaneous injection of 1 milligram glucagon. Your patient is not unconscious this time. They can still possibly take oral carbohydrates. So that would not be our direction of action this time. If you had answered letter D, have the patient drink 4 ounces of orange juice. This is already in the action phase. We know that the patient has possibly a possible hypoglycemia, right? This can quickly raise their blood glucose. However, we need to investigate first by checking their blood glucose using that finger stick blood sugar. Okay? The AccuCheck, which we actually call it in the nursing floors. This is the brand though, but we use the term FSBS or finger stick blood sugar testing. So do your assessment first to confirm the hypoglycemia. This should be your direction of care. Assessment to confirm exactly the hypoglycemia. We need to identify really if this is really a hypoglycemia. Okay. Alrighty, let's have number 15. A patient with type 1 diabetes is on insulin and propranolol for hypertension. What is the nurse concerned about? Is it A, the beta blocker may lead to insulin resistance? B, the 2 medications combined increase the risk of ketoacidosis? C, propranolol causes higher insulin requirements due to receptor blocking? Or is it letter D, the beta blocker could hide symptoms of low blood sugar? Your patient is a type 1 diabetic and currently using insulin and also propranolol for the high blood pressure. So, among the options here, what you should be worried about? Would that be letter A? Would that be B, letter C, or letter D? Yeah, this is a similar question that we had a drill on in the previous days regarding the use of propranolol or beta blocker in a patient with diabetes using insulin, right? If you had answered letter A, the beta blocker may lead to insulin resistance. Nope, this is a false statement. It does not lead to insulin resistance. The action of propranolol is basically to inhibit the effects of the norepinephrine indirol. Remember about the receptors, beta receptors. The role of the indirol here is to actually block that receptor from getting excited by the norepinephrine and epinephrine. So if this is blocked, then the patient's heart rate and also their blood pressure will be lowered. Okay, so that is the only effect about the indirol. It's a beta blocker. It doesn't cause any resistance to insulin. If you had answered letter B, the 2 medications combined increase the risk of ketoacidosis, there's no such a relationship. It doesn't have an effect on the DKA. If you had answered letter C, propranolol causes higher insulin requirements due to receptor blocking, again, it's not going to influence the insulin utilization or the glucose utilization if there is an insulin spike. Nope. If you had answered letter D, the beta blocker could hide the symptoms or mask the symptoms of low blood sugar. Guys, take note about the signs and symptoms of the low blood sugar. What do you think are those signs? One would be the tachycardia, right? Could be diaphoresis, lightheadedness, right? So these are the examples of signs and symptoms of low blood sugar: tachycardia, diaphoresis, lightheadedness. However, if the patient is taking a beta blocker, your patient will no longer be manifesting the tachycardia because we know that it can decrease the heart rate. And so even if they are hypoglycemic, they will no longer manifest that rapid pulsation because of the beta blocker. And that is the correct answer. Yeah. The beta blocker could hide the symptoms of low blood sugar. Okay. We are focusing into the pulsation of our patient as an expected manifestation of the hypoglycemia, but since they're going to be using the beta blocker, that's gonna like, yeah, they will not be able to tell. They will not be feeling the palpitation anymore. All right, we'll have the last item of the day, which is number 16. A pregnant patient with type 1 diabetes is being advised by the nurse on how to monitor her blood sugar levels. Which blood glucose monitoring schedule is most appropriate? Is it A, measure blood glucose before meals and at bedtime, or is it B, check fasting blood sugar in the morning and again at 4 p.m., or C, use a continuous glucose monitoring system, or D, test blood glucose 3 times daily and perform urine glucose testing. So your patient is type 1 diabetic, and they just knew that they're pregnant, right? So they have been type 1 diabetes. So what would be your best advice for this pregnant lady that is type 1 diabetic in order to carefully monitor their blood sugars? Yeah, that's correct, virtuous lady. Big risk to be hypertensive and be diabetic. Yeah. Because of the medications that are involved, especially antihypertensives. So the patient is already identified as type 1 diabetes. So this is something that is new to them. They already know that they're diabetic, but the pregnancy, though, is added into the mix. This is going to make their management of the blood sugar much more complicated because of the hormonal changes during the pregnancy. They need to have a much more stable blood sugar during this time. Okay? Your patient is a type 1 diabetic, but they are now pregnant. What would be the best advice, especially keeping a close watch to their blood sugar? If you had answered the letter A, measure blood glucose before meals and at bedtime, so that's basically AC and HS. The AC and HS frequency is standard to the type 1 diabetics. It is already a standard schedule. Here, the patient is pregnant. They will require much more monitoring this time. Guys, take note. Your patient is type 1 diabetic. They already know that they have been diabetic for several years. They know when to exactly check. And the ACHS is the standard checking before pregnancy. This is not the best monitoring schedule. If you answered letter B, check fasting blood sugar in the morning and again at 4 p.m., only twice a day? No, this is insufficient. If you answered letter D, test blood glucose 3 times daily and perform urine glucose testing, again, an insufficient way of monitoring their blood sugar. It's not going to really detect the changes in their glucose. It will not be helpful in managing their glucose, especially during the pregnancy. D isn't the best one. If you had answered letter C, continuous blood glucose monitoring system, this is the recommendation for this type 1 diabetic that is also pregnant. This will be the most effective method in managing their type 1 diabetes during the pregnancy. This will capture their blood glucose all throughout the day and also at nighttime. And this will allow them to administer a much more precise insulin. And also it can help manage a much more timely intervention this time. Continuous glucose monitoring. This is within the 24-hour period. There's so much complications that can happen during the pregnancy. They tend to be more hyperglycemic because of the rise of the hormones, the different bodily changes, especially with the presence of the fetus, the placental lactogen as well. So take note of those changes, guys. And it is very difficult. It's very complicated when they get pregnant. And so you gotta give them the best education as much as you can. Give them the information that would really benefit them, making sure that they can manage their blood sugar all throughout the pregnancy. And this is very crucial, especially. And so I hope that you were learning from these 16 questions. And I'll see you again tomorrow. We'll talk about type 2 diabetes tomorrow. And probably I will be incorporating some type 1 diabetes mellitus concepts. So we'll do some more exercise tomorrow. And I'll see you again at 9 p.m. Eastern Standard Time. Again, I thank you. And I hope that you're going to stick with us throughout this 90 days. So please don't forget to like and subscribe this video and also sign up for an NCLEX course. Kindly check our website and also click that link below to know more about our website. Again, thank you, everyone. You have a great day and stay safe. Bye-bye.